Good afternoon and welcome to this series of CTSNet roundtable discussions. My name is Leanne Harling and I'm here with two eminent professors of cardiovascular surgery, Professor Marjan Jahangiri and Professor Mattia Glauber. We're here today to talk about aortic valve surgery. Professor Glauber is a professor of cardiothoracic surgery at the Institute San Ambroglio in Milan, and Professor Jahangiri is professor of cardiothoracic surgery at St George's Hospital in London. Good afternoon, both of you.
Good afternoon.
I thought perhaps we could begin by talking about how things have changed and how you've both seen aortic valve surgery evolving over the last 10, 15 years or so of your careers, and where we've got to in the form of development of aortic valve surgery today.
Thank you, Leanne. Thank you for inviting us. I think there's been an international trend of mechanical valve replacement, giving more room to tissue valve replacement in terms of valve prosthesis. And also in the elderly population, the role of TAVI has expanded drastically, particularly in some of the continental countries, perhaps more so in Germany, continental Europe than England, and less in US. In addition, perhaps there'd be an occasion to discuss access of to aortic valve surgery, minimal invasive surgery. I have learned from my colleague that we both do it, but somehow different approaches. And perhaps we could discuss sutureless valve, which has been, again, a newer development in recent years.
So surely I agree that in the last years, TAVI has taken an important role in addressing this kind of therapy in more sick and more high-risk patients. And this is something that will surely continue to change the indication in isolated aortic valve disease treatment. At the same time, in the last year, two things has also played an important role. Minimal invasive is correct, and sutureless valve. Sutureless valve, I think, will change even, will play an important role in improving the outcomes. I personally believe that everything that avoid the human factor, so in that case the surgeon factor, will improve the final outcome. Surely sutureless facilitates a lot minimal invasive, so the combination of both are a good marriage for improving the results in cardiac surgery.
It's interesting you're saying about the differences in selection of patients and the evolution of TAVI. Perhaps we could begin by talking about how you've seen the change in those patients for conventional bread and butter aortic valve replacements. How have you seen that shift in demographic of patients over the last few years?
I think still in UK, the moderate or even high-risk patients, I think in the main receive a surgical aortic valve replacement and not TAVI, and I think that is the right way. Because I think the results of surgical aortic valve replacement, be it standard stenotomy or minimal invasive, whatever approach, are still excellent. And the results of TAVI are very good in very high-risk patients, but we are yet to see the 5-year outcome of the valves and their prognostic benefits as opposed to just symptomatic benefit.
And Professor Glauber?
We are used to compare, even in TAVI group of patients, the results using surgical risk predictor for the procedure. So you said something which is very important. Conventional surgery, independently from the approach, still is a gold standard. the results of TAVI surely will improve in the next future, but actually surgery, in my opinion, is still superior. We know that we have inoperable patient, high-risk patient, and this was the first indication in which TAVI was addressed. We need to be very careful when we address patients with a lower risk. We know that important studies started even in lower risk of patients, so in the so-called intermediate risk of patients. And the non-inferiority, I believe, is not the real endpoints that we need to observe or to evaluate in this therapy. Another important aspect is the cost of the procedure. We know that there are countries in which the reimbursement is an important factor to address this kind of therapy in, let's say, in high welfared countries. In the normal systems, health system, like in Italy too, we cannot pay for this therapy for each patient. Even in future, probably more or less in future than now. So that is another aspect that we also need to observe.
I guess that's something that's important when considering minimally invasive surgery as well and minimal access surgery. How do you feel that minimal access surgery has impacted on both of your practices over the last few years?
As I said, we were discussing it before we came into the studio. I happen to do limited median sternotomy incision as opposed to my colleague, Professor Glauber, who does the mini thoracotomy. He'll explain it himself. But in our practice, I would say the only thing which I think they just look better. They still go home at 5 days following surgery. I would say the blood loss is not significantly different. But what we're just beginning to measure, and I think it will be positive, is that they get less pulmonary dysfunction. For sure, they get less pulmonary dysfunction, particularly in older age population. And we're measuring the pulmonary dynamics with various chest jackets and so on. And I think that's where they do better. But overall, there is not a significant reduction in hospital stay. And ICU stay already are, if you like, median sternotomy surgical valve replacement patients were spending overnight in the recovery area. So it applies still to the minimal incision patients. So that's where I've seen the difference. They look better, they mobilize better, they go home earlier. Just a little bit, though.
Minimal invasive has changed in the last year, so many things really allowed to improve even minimal invasive. Actually, yes, we said before, sutureless valve can shorten the cost clamping time in minimal invasive, which was the weak point for this kind of approach, but surely is not the only one. There are still a lot of surgeons who do not apply this approach because in the main registry only 15 to 20% of the procedure are performed with minimal invasive. The fact is that there are many papers who prove that minimal invasive is superior for some clinical outcome in even a significant way, and this will, let's say, change these endpoints like blood transfusion, like early recovery, like post-operative atrial fibrillation or lung function, which surely shorten only 1 or 2 days hospitalization, but in my opinion, the very important aspect is that the patient don't need rehabilitation, and rehabilitation is an important resource for the health system, and they really can go home in a safer way without needing a great support from the rehabilitation
Yes.
aspect.
That's exactly our experience, that patients need less rehabilitation at home or less home care generally, the ones who have minimal invasive. And therefore, it's very useful in all the patient population. And I would say it's less cosmesis and more these factors.
Sure.
Yeah.
And it's even more important when you have an approach from the right thoracotomy instead from the partial sternotomy. Patients are standing up the next day, they are walking in the ward, they are really going home in the 5th postoperative day, and they feel better. The preoperative situation is very important. Obviously, we cannot ask
Yes.
to 85 years old patients to walk the next day, but surely the outcome, the general outcome, is much better.
And I think all the more important that when we're comparing TAVI with surgical aortic valve replacement, we really focus on the minimal invasive incisions compared to TAVI. Because if you look at the TAVI in detail, there's a lot of, we've recently shown that there is a significant change in neurocognition. There's a significant number of emboli during TAVI, particularly during valvuloplasty, which may not translate into neurocognition deficit or gross neurological event being a TIA or CVA. But these emboli are there, thromboemboli, and it's far less in surgical patients. And if we can do that with a minimal invasive incision, I think it would be a very fair comparison.
How do you select your patients for minimally invasive versus a conventional stenotomy? Do you think there's an element of patient selection bias potentially in some of the outcomes, or do you think that now we don't particularly have that? That doesn't play so much of a role in the current era?
In our practice at St. George's, every isolated aortic valve replacement on our surgical service has minimal invasive.
Okay.
And there are training cases. We have reported that 30 to 40% of our cases are completely for trainees, skin to skin, and they learn how to set it up. And some have come up with very good clues for me.
Excellent.
That's correct. I also have 100% of enrollment for minimal invasive. I perform a CT scan in all the patients because for a right thoracotomy it's better to, let's say, predict the complexity of the approach, and the CT scan gives you all the information you need, even without contrast and even with low radiation. You said, you touched an important point, that this can be a procedure for trainees.
Yes.
Sure. I personally also believe that sutureless valves are much more easier to implant than sutured conventional valves. So this has to be the first step for a resident as type of prosthesis to approach aortic valve surgery.
May I just ask, how much extra time do you think you're saving when you do a sutureless valve yourself as compared to a standard, interrupted mattress sutures? Cross-clamp?
It depends.
On average?
Yeah, on average between 20 and 25 minutes. You have to remember that the time for cardioplegia, the time for excising the valve, and decalcification, which is the biggest variable. You
Yes.
can decalcify a valve in 2 minutes or in 30 minutes. So this is a big variable. And
But that doesn't differentiate the sutureless, because you need to do that for both valves.
exactly. So the time you really can
Save.
win is the time of placing all the suture, to passing the suture through the prosthesis, and to tie. And in minimal invasive, this is something that can surely prolong the operation. And between 20 and 30 minutes are
Saving.
saving, yes.
I have to say that has not been my experience. I mean, our average cross-clamp time is between 40 and plus or minus 7 minutes, and this considerably shorter than the standard sutured, or what is reported in the literature as sutureless valve. As you quite rightly said, I think the maximum time taken during valve replacement is decalcification, taking the calcium out, and through minimal invasive can be a little bit cumbersome. So sometimes I think if you're there, you've taken the valve out, you've put the patient on bypass, you've arrested the heart, taking the valve out, then putting maybe 10 lots of mattress sutures, I haven't found it cumbersome.
Yes, but I always think that the standardization of the procedure is something that can avoid the human factor. And we will, in future, go in the direction in which everything will be done by the machine, by the technology, and even surgery will be replaced by the technology. So if a device, an implantable device, can be as reproducible as much in the way of implant, I think it's the best way to
develop.
To develop.
Sure,
yes.
I think that's a fair point.
And with the sutureless valves, there are obviously still limitations, particularly with regards to annular size and the valve fitting the patient per se. How do you feel? There's obviously still some way to go with development there. What's your feeling on that?
There are sufficient data to say that sutureless valve has a superior hemodynamic performance. So we can implant valves with a bigger orifice area independently of the size, because we know that each valve has a different way of sizing. But we can, in the same patient, obtain a bigger orifice area with a sutureless valve than with a sutured valve, and an improved hemodynamic performance at the same time will mean better quality of life, but at the same time durability of the prosthesis. Lower gradient means higher durability of the valve itself. So this is another important aspect to reason to choose a sutureless valve.
Excellent. Well, thank you very much, both of you. We've covered most of aortic valve surgery from beginning to the present day. So thank you very much for a very interesting discussion.
Yeah, thank you very much.
Thank you.
Thank you.
Thank you.